To join to subconference, press number of subconference from 1 to 4, or press star to return to the conference. To join to subconference, press number of subconference from 1 to 4, or press star to return to the conference.
So, whenever you're ready to start. I'm ready whenever you are. Okay, we'll give it a... Welcome. This lecture was made in consultation with subject matter experts and clinicians who have worked with Rocky Mountain spotted fever cases in Arizona. The presenters today are Haley Yaglin, epidemiologist at the Arizona Department of Health Services, and Naomi Drexler, epidemiologist at the Centers for Disease Control and Prevention. Rocky Mountain spotted fever is caused by a tick-borne bacterium called Rickettsia rickettsii. This disease occurs throughout much of North and South America and is found in several different tick species. RMSF is carried by a different tick vector in other parts of the United States compared to what we see in Arizona. Rickettsia rickettsii is an intracellular bacterium which infects endothelial cells, the cells that line the blood vessels. Because of this, clinical presentation is very specific. Rocky Mountain spotted fever can cause widespread vasculitis, leading to damage to all organ systems. But the good news is that RMSF is a treatable disease, particularly with doxycycline, as you will hear in this presentation. Rocky Mountain spotted fever was first seen in Arizona in the early 2000s from an American Indian reservation in eastern Arizona. And since then, there have been over 330 cases of RMSF reported. Majority of these cases have been isolated to those 6 Indian reservations that you see on the picture on the slide. Our cases tend to be younger in age, and our incidence rate is about 150 times higher than the U.S. average, also with a slightly higher case fatality rate. There have been 20 deaths due to Rocky Mountain spotted fever in Arizona as well since the early 2000s. So what's different about RMSF in Arizona? Well, our tick vector is different. In Arizona, the brown dog tick, also known as Rhipicephalus sanguineus, is spreading RMSF in this part of the country and also in some parts of Mexico. The brown dog tick, as seen in this picture, is the most common tick in the world. However, as mentioned previously, this is not the tick that tends to cause Rocky Mountain spotted fever cases in most of the U.S., but it is in Arizona. And this is primarily because this tick loves to live and completes its entire life cycle by feeding and breeding on domestic dogs. On these Indian reservations, we've seen high numbers of free-roaming dogs, and therefore this particular tick vector is able to flourish. The brown dog tick is not as sensitive to climates as other species of ticks, and it loves to live around people's homes. This is why our cases tend to have occurred in clusters due to common household exposures. The other unique component is that because of the warmer temperatures in Arizona and common infestations of these ticks in and around homes, this brown dog tick can remain active all year round, and therefore we do tend to see human cases of RMSF all year round, with peaks being around May and August.
Rocky Mountain spotted fever is a rapidly progressing illness, which usually starts with fever, headache, and muscle pain 3 to 12 days following the bite of an infected tick. Within 2 to 4 days of illness, some patients may develop gastrointestinal signs like abdominal pain, nausea, and vomiting, or may have respiratory signs such as cough or difficulty breathing. A rash may occur during this time, but is often not present. Thrombocytopenia, hyponatremia, and elevated liver enzymes may occur but are typically mild and cannot be relied upon for an early indication of Rocky Mountain spotted fever. Patients typically present for care within the first 2 days of symptoms because they are feeling very ill at this time. So clinicians are most likely to see these nonspecific manifestations early on at the first site of visit. The spotted part of Rocky Mountain spotted fever refers to the rash, which is present in the majority of cases, roughly 90%, at some point during their illness. However, less than half of patients have rash within the first 3 days of illness when they are typically seeking medical care. Rash descriptions can be highly variable for patients with Rocky Mountain spotted fever, and early rash is typically described as macular or maculopapular, often starting on the wrists and forearms and spreading centrally and distally. This table comes from a chart review of cases of Rocky Mountain spotted fever, specifically in Arizona among tribal residents. As you can see, fever is present in 81% of Arizona cases and is the most reliable symptom. If you try to combine fever and rash and fever and history of tick exposure, as is sometimes recommended in the older literature, you will miss over half of patients. And the triad of fever, rash, and history of tick bite is only present in a minority of cases and cannot be relied upon for early diagnosis. While fever is the most commonly reported symptom, afebrile cases do occur, and a lack of fever should not rule out the possibility of RMSF, particularly in patients who present latent disease progression who already have signs of organ failure or sepsis. This table shows an additional symptom list which are commonly recorded amongst Arizona RMSF cases. Abdominal symptoms, respiratory symptoms are frequently reported, and altered mental status can be reported, although this is a later finding. Because symptoms are highly variable and no combination of symptoms and signs can be relied upon for early identification of Rocky Mountain spotted fever, treatment is usually based on 2 or more days of fever and is the most consistent way to treat RMSF early and prevent death. As the disease advances, there will be increasing signs of vascular damage throughout the body, and severe vascular damage may be irreversible. Injury to the vascular endothelium results in increased capillary permeability, microhemorrhage, and platelet consumption, resulting in hypovolemia and thrombocytopenia. Late-stage manifestations of Rocky Mountain spotted fever usually occur at day 5 or later of symptoms. This is where we see a more profound shift in symptom onset, including the development of late-stage petechial rash, more advanced symptoms such as hypotension, development of neurologic signs such as altered mental status and seizures. Compromised blood flow in the extremities can begin to cause necrosis of the digits and limbs. At this time, hyponatremia and thrombocytopenia are often present, and elevations in liver enzymes are nearly always present, but may be more profound in adult patients. The classic Rocky Mountain spotted rash, which is the petechial rash involving the palms of the hands and the soles of the feet, does not typically occur until day 5 or 6 of symptoms, after the point in which doxycycline should already have been administered. Petechial rash represents microhemorrhages in the dermis, and if you see vessel damage in the skin, you know that it is likely occurring in other organ systems. The physician's goal is to prevent this rash from appearing by treating early with doxycycline. The site of endothelial injury determines the major clinical manifestations. If this injury is occurring in the lungs, this could lead to onset of pulmonary edema. If it's occurring in the brain vasculature, you may see cerebral edema, etc. Severe late-stage manifestations of Rocky Mountain spotted fever include meningoencephalitis, acute renal failure, ARDS, cutaneous necrosis, shock, arrhythmia, and seizures. In addition to fatal outcome, patients who have severe illness but survive may experience long-term sequelae, including hearing loss, blindness, cognitive defects, and amputation of limbs. Risk factors for fatal outcome include delayed onset of rash, advanced and young ages, and underlying health conditions such as alcoholism and chronic lung disease. Some of these risk factors may be suggestive of alternative diagnoses and will often lead to a delayed recognition and treatment of Rocky Mountain spotted fever. Of course, the most important risk factor for fatal outcome is this delay in doxycycline administration or use of an alternative antibiotic therapy. As you can see, RMSF is not easy to diagnose. and in fact, between 60 and 85% of RMSF cases nationwide are misdiagnosed in their initial evaluation. And this is likely because the clinicians are seeing patients in these early stages of illness, day 2, day 3, where there are nonspecific symptoms present, which are difficult to ascribe to Rocky Mountain spotted fever. However, because RMSF progresses rapidly and half of death occurs within the first 8 days of symptoms, there is little room for delay. Early empiric treatment with doxycycline is the best way to prevent RMSF progression. Doxycycline is the treatment of choice for all suspected RMSF in persons of all ages and should be started as soon as there is suspicion of RMSF. Treatment should never be delayed for appearance of a rash or results of diagnostic testing. The use of other broad-spectrum antibiotics, especially sulfa derivatives, have been associated with more severe illness and death. Historically, tetracycline antibiotics have been contraindicated in children under the age of 8 due to the result of dental staining and enamel hypoplasia. However, a new study with the CDC and IHS has shown that short courses of doxycycline, such as those used to treat Rocky Mountain spotted fever, do not result in these adverse effects when used in children less than 8 years, even in multiple courses. Data also suggests that the risk of short-term use of doxycycline during pregnancy is unlikely to cause substantial tetragenic risk. However, we cannot say that no risk exists. Cases of RMSF with life-threatening tetracycline allergy or patients who are pregnant at the time of illness should be evaluated on a case-by-case basis, weighing the risks and benefits of each treatment option with the patient and their families. Lastly, it should be noted that prophylactic use of doxycycline following a tick bite but before the appearance of symptoms is not recommended. Doxycycline is rickettsiostatic, not rickettsicidal, and use of doxycycline before clinical illness may simply delay the onset of symptoms. In high-risk tribal areas such as San Carlos, this algorithm is recommended to help identify and treat RMSF patients. The algorithm encourages clinicians to think about RMSF in patients with 2 or more days of fever, including self-reported fevers. Patients meeting this criteria should be prescribed doxycycline and have acute RMSF titers taken. Patients should also be enrolled for follow-up convalescent testing 2 to 4 weeks following. If patients are seen on day 1 of fever, the algorithm encourages clinicians to follow up with patients the next day, and if the patient is not markedly improved or is worse, they need to be reevaluated for RMSF and started on doxycycline. RMSF may be one of several etiologies being considered. Thus, we encourage clinicians to prescribe doxycycline in addition to treatment for other causes. I call this Doxy Plus. It's important to remember that co-infections of RMSF and other infections have been documented, so evidence of other causes of illness, such as positive urine cultures, does not eliminate the possibility of RMSF infection as well.
There are a variety of diagnostic tests available for Rocky Mountain spotted fever. PCR, or immunohistochemistry of whole blood, serum, and tissue, can be evaluated, and this might be particularly helpful for individuals in the severe stage of illness or individuals that have died of suspected Rocky Mountain spotted fever. The gold standard, however, for diagnostic testing is serologic testing by immunofluorescent assay. This detects antibodies, particularly IgG, and requires paired sera, the acute specimen, which should be taken early after symptom onset, and then a convalescent titer 2 to 4 weeks later. The goal is to look for a 4-fold rise in antibody titers, and that would be considered confirmatory diagnosis for Rocky Mountain spotted fever. Testing for Rocky Mountain spotted fever is available commercially for serology, and for other testing, such as the PCR, we suggest you contact your local public health nursing, the Arizona State Department of Health Services, and we can coordinate additional testing with the CDC. Timing and specimen options are also important to consider. Most patients will be seen soon after illness onset, as you heard previously. And again, these patients should have an acute serum sample taken after their first visit and then scheduled to return for the convalescent titer. If a patient does present with some type of rash, the rash may also be biopsied. Rickettsia may be detected in severely ill patients in the whole blood or in postmortem samples as well. Rocky Mountain spotted fever is a reportable disease, and it's very important to report all suspected, probable, and confirmed cases to your tribal health authorities and local and state health departments. On high-risk reservations like San Carlos, the clinic should have a way to connect with public health nursing or community health representatives to refer patients to assist with education, follow-up, scheduling for convalescent titers, and also an environmental health assessment of the home to look for ticks and to assess dogs that might be around the home. These efforts are going to be extremely important for public health investigations to best understand our burden of Rocky Mountain spotted fever in Arizona tribal lands. One of the most important parts of the algorithm, as mentioned previously, is ensuring next-day follow-up for patients with only 1 day of fever or for asymptomatic individuals that may be presenting with tick bite. It can be challenging for tribal representatives to return the next day, so it's very important to communicate with your public health nursing and community health representative staff to assist in follow-up with patients. Even waiting a few more days can cause severe or fatal outcomes of Rocky Mountain spotted fever. Insist on following up with the patient, even if it's by phone. Make the patient an appointment before discharging them. Public health nursing has convalescent titer return cards and a lot of materials for Rocky Mountain spotted fever education, including what symptoms to look out for and phone numbers to contact if additional symptoms do occur. In Arizona, there's also a protocol for transfers of septic patients from high-risk reservations. All septic patients transferred to referral facilities should be started on doxycycline before the transfer. Never delay the doxycycline if you suspect Rocky Mountain spotted fever, even if the referral facility requests it. Make a note in the transfer orders about why the patient is on doxycycline and generate a referral to public health nursing. The public health nursing staff will reach out to other public health organizations, including local and state authorities, and assist with the follow-up of that patient once they leave the tribal healthcare facility. This slide shows the graphic of our transfer protocol, which is important for the promotion of continuation of patient care and treatment from tribal healthcare facilities to non-tribal healthcare facilities. The goal of this transfer protocol is to prevent case information gaps, facilitate communication and collaboration between jurisdictions, and save lives. There are success stories on San Carlos with using this protocol. In summary, we know that Rocky Mountain spotted fever can be rapidly fatal, even in previously healthy individuals. Early diagnosis based on those clinical manifestations may not be so helpful in determining if an individual has suspected Rocky Mountain spotted fever. And those laboratory results from acute serologic testing are also not going to be very helpful. So it's always important to treat empirically with doxycycline and not wait for the laboratory results or wait for more clear clinical signs to occur. The use of the algorithm for high-risk reservations can also be very helpful. Remember that doxycycline is the drug of choice for all patients, including children, and always can follow up with public health nursing to do investigations and to have environmental individuals go to homes. Rocky Mountain spotted fever surveillance is important for community public health decisions and again should not be used for treatment. Clusters of cases can be prevented by communicating with families, local health departments, public health nursing, animal control, Indian Health Service environmental health officers, and your Rocky Mountain spotted fever control officers. There have been excellent success stories with combating and reducing cases of Rocky Mountain spotted fever on Arizona tribal lands because of the environmental health work done for tick collaring dogs, pesticide spraying of homes to prevent these brown dog ticks, and also educating the community for reservation-wide campaigns that occur twice a year on San Carlos. Rocky Mountain spotted fever can be prevented by reducing these tick exposures in and around homes and educating the community. RMSF is a preventable, treatable, and fixable problem. For more information, the CDC has recently released updated guidelines for the diagnosis and management of tick-borne rickettsial diseases. And for any other questions or concerns, we suggest that you contact your local public health nursing. For reporting Rocky Mountain spotted fever cases, planning efforts, or other clinical inquiries, the contact information for the Arizona Department of Health, Intertribal Council of Arizona, and CDC Rickettsial Zoonoses branch are available on this slide. Thank you for listening to this presentation about Rocky Mountain spotted fever in Arizona, and we ask that you please contact Jeanette Brislin with Public Health Nursing to complete a brief evaluation.